bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Children's Sleep Problems, Importance, and Solutions, Introducing Better Nights, Better Days. So as I mentioned, it has, I think, been almost 2 years since I first was in contact with Dr. Penny Corkum when they were starting this the CIHR team grant research about pediatric sleep, and it immediately struck us as something that our community would be very, very interested in. So we began trying to work on the project, or on a presentation at that time, and they just always had great results coming out around the corner, so we kept pushing it off, but we're finally here, so it's really a great pleasure to welcome Dr. Penny Corkum and her team to the CAFC Presents stage, because I think it's really going to be a great presentation. Dr. Penny Corkum is a registered psychologist and professor in the clinical psychology program with the Department of Psychology and Neuroscience at Dalhousie University, with cross appointments to the Departments of Pediatrics and Psychiatry. Her clinical practice, research, and teaching are all in the area of child psychopathology. And joining Dr. Corkum is Dr. Wendy Hall, who is a professor at the University of British Columbia at the School of Nursing, and her research focuses on the transition to parenting and infants and young children's sleep. She examines the effects of behavioral sleep problems on infants and their parents, and is developing interventions to promote healthy sleep. And last but not least is Dr. Graham Reid, who is a clinical psychologist and an associate professor with a joint appointment in the Departments of Psychology and Family Medicine, and a cross appointment in pediatrics at Western University in London, Ontario. And Dr. Reid also holds an appointment as a scientist at the Children's Health and Therapeutics program at the Children's Health Research Institute. So without any further ado, it's my pleasure to hand the virtual podium first off over to Dr. Graham Reid at Western University in London, Ontario. Over to you, Dr. Reid.
Great. Well, thanks very much. It's a pleasure being here. And I'm going to start off and give you a bit of an overview, kind of a primer on sleep and its impact. And then Wendy's going to talk about common sleep problems and their treatment. And finally, Penny's going to talk about our Better Nights, Better Days treatment program, which is a web-based intervention for parents ages 1 to 10, which I think you'll find very interesting and probably highly appropriate for many of the children that you work with. So let's jump in. Interrupted sleep is a form of torture in prison camps, and there's a reason why. It's brutal. I was so exhausted that I walked into a wall in my house that had been there like forever. When you're so tired that you walk into stationary objects, it can't be good. This was a quote from a mom in one of our studies, and she was reflecting on what it was like to have a child with problems getting to sleep and staying asleep. And it's well known in the community that children's sleep problems are an issue. This was an editorial that I pulled from the local paper here in London, Ontario, and it was a tragic story of a father who had actually stabbed his young child, a 5-year-old, and this rabbi jumped in to not defend the father or trying to assume that he was innocent, but just to say that if any parent tells you that they have never felt helpless and overwhelmed by the challenge of parenting, they would be lying. If the children were up all night, and if you need to be up in 30 minutes to go to work, and you just put your baby down in his crib, and you try to catch a short nap, when the 5-year-old bursts into your bedroom demanding to be given her cereal that very instant, it can definitely be a trying morning. So whenever we think about children's sleep problems, we also have to remember that children's sleep problems are really a family problem. Because people who say that they sleep like a baby, they usually don't have one. Now, let's take a quick look at kind of what is sleep like. Here's a graphic representation of what sleep across the night might look like. We can see a few things here. So we see that children kind of go through these, what we call cycles of sleep, and they spend more time in the deep kind of restorative sleep of stages 3, 4 early in the night. And this is usually assumed to be the most physiologically restorative sleep. And as the night wears on, they're spending more time in REM sleep, rapid eye movement sleep. And REM sleep has been associated more with kind of cognitive processing and emotion regulation. We see a couple other key things, that children spend some time during the night awake, a short period of time, hopefully early in the night when they fall asleep, and that children wake at various points. Children wake during the night, so do adolescents, so do adults. The issue is not that we wake at night. The issue becomes a problem when children have difficulties reinitiating sleep on their own. And Wendy's going to talk more about that. So from this we can see a number of things, right? We might want to look at sleep duration, the total amount of time from when they're in bed to when they get up that they're spent asleep. And we also might want to consider sleep efficiency. So subtracting or taking a ratio of the time that they're in bed, including these times that they're in bed and awake, divided by the time of sleep divided by the time in bed gives us a measure of sleep efficiency. There's a number of things we have to also consider and understand with sleep. So if we take this little guy here, he has a high drive for sleep when he starts the night, and that drive for sleep resets to 0, and then that process repeats. Now, if this was the only thing that was determining sleep, sleep would be relatively simple. But there's another cycle that goes on during the day and the night called the alerting cycle. So in the wee hours of the morning, this isn't very active, but it increases, and we get sort of a bit of a peak right before lunch. Now, after lunch, there's a bit of a dip. If you're a toddler, this would be when you're taking a nap. If you're like many adults in North America, this is where you're having a coffee or some other form of caffeine. And then as the day wears on, there's another kind of a peak sort of in this alerting cycle that occurs shortly after supper. And this is important for parents to know for a couple reasons. One is that if they see their child after supper being quite active, they might misinterpret this as meaning that he really doesn't need that much sleep. The other is that if you try and put a toddler to bed when they're in this state, it's just not going to happen. Now these two cycles, the sleep drive and the alerting cycle, work in concert. In this diagram we see that the sleep drive is represented as these black bars that are pushing down. So as the day progresses, the drive for sleep becomes greater and greater. Now if this was the only thing that was happening, people would be starting to nod off at any time during this period of time. But we also have this alerting cycle. So again, this is kind of pushing up in the morning. And you can see here that the alerting cycle and the sleep drive are kind of counteracting each other until, and this is more likely to be an adult than a child, this alerting cycle drops off right when the sleep drive is at its peak, and this contributes to being asleep. So we can see that this is actually a fairly complex process. And our bodies have biological clocks in virtually every cell. But these clocks need to be reset. They don't run true without a couple things. One thing that is key to keeping our biological clock in sync is our rise time. The other is light. And in North America, with the changes of seasons and our variable daytime, we often can't control how much light we're being exposed to, but we can control rise time. And when Wendy talks about sleep interventions, you're going to see that there's a lot of importance given to regularity of routines and rise time, and this helps to keep children's and our biological clocks in sync. Now, when we think about sleep over the course of a week, we can see that it can have different effects. So here's our little friend Ethan, who has sleep drive is high, it resets to 0, and that continues as the week goes on. But his buddy Jake here, he's got a high sleep drive on Monday, but it doesn't come back to 0. And this continues as the week goes on, so that in essence he's accumulating sleep debt. And unlike governments, sleep debt has to be repaid. For adolescents in particular, we see that they often sleep very late on Saturdays. They're repaying their sleep debt. With children, it varies a little bit, and it may not be quite as pronounced as I have on this graph. But one of the things when we start thinking about the impact of sleep is that many children may be functioning with chronic low levels of sleep debt, and that can affect their daily functioning. So what is normal when it comes to children's sleep? Well, this graph shows the average of children's sleep from infancy through to age 16. So a couple key things. We can see that there's a fairly linear relationship between duration of sleep across this age period, with children at age 2 on average getting about 13 hours of sleep, 5-year-olds about 11, and 10-year-olds about 10 hours. But there is wide variability around this average. So there are some 2-year-olds who are sleeping about 11 hours and others about 15 and a half. And there are some 10-year-olds who are sleeping about 9 hours and others who are sleeping about 11. So this is what is occurring in the population, what we might consider as normal variability. But what is normal may not be what is optimal. And working from the current recommendations that were published in 2015 from the National Sleep Foundation, this figure shows the not recommended sleep durations by age here in red. The may be recommended in yellow, and kind of a light green is the recommended. So you can see a couple things. One, if we look at this upper level, not many children are falling into the upper ranges in terms of long sleep duration. There are many more children who are into this. It might be okay to be sleeping this little, but it also might not be. So on average, the takeaway from this is that there's probably a tendency within the population for too many children to be sleeping not enough. When we represent this in graphic form, or a table form, you can see that this has different age categories and recommended hours of sleep. Now, this publication tried to cover sleep across the entire lifespan, and I think they did a bit of a disservice by lumping all school-age children 6 to age 13 into one category, because the average sleep varies at least an hour between the 5-year-olds and the 13-year-olds. So the recommended hours of sleep is going to be at this upper end for the 6-year-olds and might be closer to this lower end for the 13-year-olds. Again, we see there's a range in terms of recommended, and for a few children it might be a bit less or a bit more. And there's clearly categories that you may be sleeping excessively or clearly not enough. But how do we make this determination on an individual for an individual child as opposed to the population? Well, in that case, we need to consider the impact of sleep. So I got a little question for you, and I think there's going to be a poll posted, and I encourage you to respond to this poll. So Jeremy's 5, and it takes him about 11 hours. He sleeps for about 11 hours. From when parents say go to bed to being asleep takes about an hour, and parents are at their wits' end. Now, which of the following would you say are true? That Jeremy is not getting enough sleep. The real problem is Jeremy's parents. Jeremy's probably having difficulties in school, or we really need a sleep study, an overnight kind of polysomnography in the lab to understand what's going on, or none of the above are true. I'm going to encourage you to respond to this question, and then I'm going to discuss the answers later in the talk. So what do I do with sleep? Well, based on my quick overview, we can see that there are some aspects of sleep that are related to our physical functioning, so it might impact that aspect during the day. And there's a lot that has to do with our brain. And so we know, and when we're looking at the effects of sleep on children, we might want to look at it in terms of their learning, but it also has to do with emotion regulation. So that might impact their social relationships and their relationships within the family, and we can't forget that children's sleep issues are really a family issue. Now, everybody sleeps, and some love it. We have happy kids, we have a happy marriage, we have a happy home, but more importantly, we have good sleep. Sleep deprivation is nasty, nasty, nasty. So this was a quote by one of the moms in our studies who, in fact, had good sleep, but she was well aware of the impact of sleep deprivation. Because without enough sleep, we all become tall 2-year-olds. So there is a general understanding that when we are not getting enough sleep, we become tall 2-year-olds, meaning that we have problems with emotion regulation, we have difficulty with problem solving and negotiating interpersonal interactions. But what if you're a 2-year-old who is having sleep problems? Maybe the impact is even more significant. So we do know that there's a relationship between sleep and daytime functioning, that children who are having sleep problems are also tending to have more emotional and behavioral problems. Well, which came first? In observational studies, we can't disentangle kind of causation. And there has been some work to try and look at what happens when you manipulate sleep problems and its impact on emotional and behavioral problems during the day. In some ways, from a clinical point of view, the direction of the relationship is not really all that critical. Hopefully, as you'll see by the end of the talk, the interventions for sleep are quite effective and not really that intensive. And so intervening for sleep may not really depend on understanding which of these relationships is causal. So at first we know that if children are having sleep problems, they're probably going to be sleepy and fatigued. However, in some children, sleep may appear as increased arousal. And both parents and sometimes professionals may inadvertently think that children are struggling with being inattentive, even hyperactive, when in fact it's really that they're not getting enough sleep. We can also see that when children are having problems with sleep, that they may be more irritable and have more negative mood, but sometimes they may even be a bit giddy, particularly with that kind of alerting cycle right around supper, which may in turn create issues for parents. They have difficulties regulating attention and mood, and there is also some impact on their biological functioning. So there's a couple recent meta-analyses that looked at the relationship between sleep duration and its effects on cognition and psychopathology. And in this review article, they focused exclusively on healthy children. They weren't looking at children with any other comorbidities or even, in fact, children who were known to have sleep problems. And what they found was that sleep duration was related to poor cognitive performance, issues with executive functioning, which refers to kind of the skills we need to think about dealing with problems in a flexible way, to have self-control, and to be disciplined. And as well, just gross measures in terms of cognition of school performance. The effect sizes are about 0.15 standard deviations. So again, this is the population and amongst healthy children. It's also related to psychopathology, whether we think about emotional problems, anxiety, depression, or behavioral problems and inattention. We see that sleep duration is related to, short sleep duration is related to greater problems. Now, interestingly, there were no significant effects for sleep efficiency. The handful of studies that have tried to manipulate sleep in healthy children and looked at their cognitive and behavioral outcomes, they have found relatively consistent effects, but my read on this literature, and it's not really that extensive, is that when children are randomized to have extended sleep or shortened sleep, what seems to be a fairly consistent finding is that when their sleep is lengthened, even in healthy children who have no sleep problems, they tend to do better in terms of their cognitive performance, emotional functioning, and their behavioral problems. So this suggests to me, anyway, that probably a good number of children in the population are not getting enough sleep. There's also been a fair amount of interest looking at sleep duration and the prevalence of obesity and overweight. So in cross-sectional studies, and this is with children who go from preschoolers right through to young adults almost, there's a fairly consistent relationship, whether you look at it cross-sectionally or longitudinally, the children who are having short sleep duration, defined in various ways in these studies, and again, I provide a reference here, they have between 1.5 to almost 2 times the likelihood of having issues with obesity and overweight. So again, when you think about their cognition, their behavior, and obesity and overweight, sleep has significant effects on children. But we can't forget that when children have sleep problems, it impacts their parents. Children's sleep problems have been related to increased sleepiness and fatigue amongst parents, and some to the extent that they'll walk into walls. But it's also been related to maternal depression. And again, sleep problems in children tend to have a slightly greater effect on moms than dads. It also is related to parenting stress and stress in general. And the way that I tend to explain this to parents is it's kind of like you got sleepy, cranky, irritable kids interacting with sleepy, cranky, irritable parents, and that's a recipe for stress in general. And again, when moms are stressed and they're stressed in the home, perhaps not surprisingly, marital satisfaction also suffers. So if we go back to Jeremy, now I'm not sure where the poll results show up here. Can we see the poll results?
Put the poll results up. So of the 5 choices, the most common response was none of the above are true, at 64% of the audience saying that. 17% said the real problem is Jeremy's parents. 12% said he needs a sleep study to understand what's going on. 5% said Jeremy is not getting enough sleep, and 1% said Jeremy is probably having difficulty in school.
Okay, so it was a bit of a trick question. My best answer would be that none of the above are true. We don't really know whether Jeremy's getting enough sleep. On average, 5-year-olds will be getting 11 hours, but you'd want to look at what his functioning is like, and he may be having difficulties in school, which might indicate that 11 hours is not enough sleep. The real problem isn't necessarily Jeremy's parents. If you're battling with a child for an hour every night to go to sleep, there are issues there, but it's not really the parents' fault. And in terms of a sleep study, when we think about these common problems with children's sleep, sleep studies virtually never indicated, with some exceptions, and Wendy's going to cover some of these. So at this point, we have a few minutes for questions before I turn it over to Wendy, and I think the questions should show up in the chat. Is that correct?
No, the questions will come into me, or Ann and I here at the CAFC office, and we'll certainly let you know if we do get any questions. We don't have any yet, but as I mentioned at the beginning, we do remind people to type their questions in as they think of them. Don't feel we need to wait until the next break for questions. And if you do have any questions for Dr. Reid, we will certainly be getting to them at the end. We did have some questions about the recording being available and the slides. And we certainly do record all the sessions and make those available after the fact and on the Knowledge Exchange Network, and you will get information following the webinar on how to access those. So we did have a couple of questions come in, and just as we're handing over to Dr. Hall, we'll just take a couple of quick questions here. So Dr. Graham, or Dr. Reid, could you share the equation for determining sleep efficiency?
So the equation for sleep efficiency is pretty simple. You take the total sleep duration, and this would be measured in different ways. Sometimes you can simply ask parents for the time that the child went to bed and the time that the child woke up. Other times we'll use what's called an actigraph, which is a small watch-like device that assesses movement, and you can quantify sleep or wakefulness. So whichever measure you use, you get the total time of sleep, and then you get the total time in bed. This is from when a parent says, "Good night, I love you, see you in the morning," and the child should be in bed, to when they get out of bed at the end of the night or at the beginning of the morning. So that percentage time in bed asleep is a measure of sleep efficiency.
All right, and the next question that we'll just take a couple for now, and we'll save the rest for the end, but the next question is, are there any ill effects of too much sleep for children?
I think we haven't really examined the effects of too much sleep, so I don't have any studies off the top of my head that have done that, in part because really I think in the population seems to be a tendency towards too little sleep. As a psychologist, the obvious things that would jump to my mind is if kids are getting too much sleep, is that it may be related to a mood issue, right? So you could think it, starts to wonder, are children maybe a little bit depressed? But I don't know any studies off the top of my head looking at that. Perhaps one of the other presenters might have seen that.
All right. And if any of our other presenters do have anything to contribute to any of these answers, please don't hesitate to jump in. But for now, I think we'll wrap up that little bit of questions there. We do have a few more in the list, and we'll certainly get to those at the end. But for now, we're going to head out to the West Coast, where Dr. Wendy Hall got up bright and early to join us today. So we'll go over to you, Dr. Hall.
Thanks, Doug. It's a pleasure to be here, and thanks for inviting us to present to your group. I'm going to be talking about common sleep problems and treatment of common sleep problems. It's early here. And then we'll move on to Penny's presentation. So I'm actually starting my presentation with a poll question. And the poll question is, what proportion of typically developing young children has sleep problems? And you can choose between 5 to 10%, 40 to 45%, 20 to 30%, or 50 to 60%. So I'll pause for a second while you answer that question.
All right, we'll close that off. And it looks like that 65% of the audience, the vast majority, said that 20 to 30% of children have a sleep problem. Typically developing young children have sleep problems, followed by 20% of the audience saying that 40 to 45% have sleep problems, followed by 8% saying 5 to 10% have sleep problems, and 7% saying 50 to 60% have sleep problems.
Thanks for sharing that, Doug. So we have a very well-educated audience here, because it is 20 to 30% of young children who have been reported to have sleep problems. Now, the interesting point about this is usually with young children, it's parents who define whether a child has a sleep problem or not, and only with older children that they identify their own sleep problems. And what's a problem for some parents may not be a problem for others. So there's some parents who have a high degree of tolerance for night waking and children getting up during the night, or going in and sleeping with their children in their beds to try and get them to sleep, and other parents who really prefer not to do that and find that very difficult. So it is important to explore that with parents. Generally, as Graham was pointing out, we look at sleep time being shorter than age-appropriate norms, and the child showing evidence of sleep loss. And as Graham said, that can be sleepiness and drowsiness, but for a lot of children, it can also be irritability, inattention, impulsivity, and hyperactivity. So that's when we start to get a sense of sleep problems. And also, as Graham was saying, we all come up into light sleep states during the night and have brief periods of arousal or wake. But good sleepers learn to go back to sleep on their own, and poor sleepers have not learned how to self-soothe after waking. And we're going to talk more about this when I get into talking about treatments, because really a lot of the treatments are about children helping children figure out how to self-soothe who are having night waking, or how to go to sleep on their own who are having problems with falling asleep. So generally, we talk about two kinds of sleep problems, dyssomnias and parasomnias. And I appreciate that with the new guidelines for mental health, they've moved sort of past those descriptors. But I think for all of us who are working with families with children with sleep problems, it's helpful to retain that perspective about dyssomnias and parasomnias. It makes sense from a clinical standpoint. So an insomnia or dyssomnia is when children have trouble falling asleep or staying asleep at night. This is an old definition of a sleep problem, but I really like it a lot. It's from the American Academy of Sleep Medicine. And I have found over the years that if children are waking 2 or more times per night, or more than 20 minutes per night for more than 2 months, or taking more than 20 minutes to settle, for a lot of parents, this constitutes a sleep problem. And for professionals, too, they would see that as a problem. And common causes of sleep problems are sleep habits, limit-setting problems, usually on the part of parents, and often inadequate sleep environments. And the thing about this is that some children outgrow sleep problems, but often parents find it very unhelpful to go to a healthcare practitioner and have them say, oh, don't worry about it, your child will grow out of it, it's just a normal stage they're going through. Because for a lot of children, it's not just a stage, it lasts for extensive periods of time, and as Graham pointed out, it has profound effects on parents and families. And I'm writing a paper right now looking at depression, parental depression coming out of a randomized controlled trial that we did, and the levels of depressed symptoms that parents report are quite alarming. So what are some of the negative sleep onset associations that are connected to what we see as sleep problems? A big one is children requiring parental presence to fall asleep, with parents feeling guilty unless they have active involvement in settling. And some of this comes, I think, in my experience, out of the attachment parenting movement, where there's a sense that parents need to be with their children pretty consistently, and leaving children to figure out how to fall asleep on their own is often not regarded as acceptable if you're coming from that philosophical position. Sometimes if infants are sharing parents' bedrooms after the 6-month sleep window, which is recommended by the Public Health Association of Canada, that they be in the parents' room for the first 6 months, that can have a negative sleep onset association, partly because the infants, when they come up into these arousal states, can see their parents, but also parents can be incredibly noisy when they're sleeping. They can snore, they might hit objects during the night, etc., and that can interfere with a child's sleep if they're a light sleeper. If we've got children that are more than 6 months of age and they're being breastfed to sleep or given bottles to sleep during the night, that's also a sleep association that can be problematic for them, because when they come up into these arousal states during the night, if they're not feeding to go into the deep sleep, they fully wake looking for that sleep association to help them get into a deep sleep. We have to look at whether children are being brought into parents' beds when the parents don't have a family bed sharing philosophy. We call that reactive co-sleeping, and what that means is parents don't really want to share their beds with their children. They're only bringing their children into bed with them when they're absolutely desperate and they can't figure out any other way to try and help them sleep. And the problem with reactive co-bedding or reactive co-sleeping is often parents are actually quite angry about that, and they really resent the fact that they're having to share their bed with their children. Another negative sleep association that I'm going to talk about a little bit more shortly is late bedtimes after 9 p.m. And it's really important when we're working with families with children with sleep problems to pay attention to what's going on over 24 hours a day, not just what's going on at night. Often individuals will zoom into what's happening at night and not ask questions about daytime naps. And if children aren't getting adequate naps in the daytime when it's developmentally appropriate for them, that can cause them to be more hyperactive as the day wears on. They're having more meltdowns, and they can be harder to settle for sleep, and they can wake more frequently during the night. And a lot of parents don't realize that because they don't understand that it's kind of intuitively not obvious that this would happen with parents or children, because with adults, often if we're not getting enough sleep through the day, we just get really, really tired and we just fall into bed and drop off to sleep. And actually, you'll get some parents who think that they can help their children sleep better at night if they get rid of the daytime naps, which in fact actually makes the problem worse or exacerbates the problem. So irregular and inconsistent daytime and nighttime routines really contribute to sleep problems. And it also follows that inconsistent meal times and feeding during the day or feeding just before bed can, as I mentioned previously, contribute to sleep problems. And lack of quiet activities as part of the routine, like singing a lullaby, reading a book, and I mean a hard copy book, not a Kindle, and staying within a 20 to 30 minute time frame, if those aren't established, that also interferes with sleep. And Mindell's done some wonderful work on this, looking at what the effects are of implementing routines for toddlers and infants, and found that not only does just implementing the routine help toddlers and infants to sleep better through the night and have more consolidated sleep, but they wake up with better moods in the morning, and parents are less likely to identify them as having a sleep problem. One of the problems with routines, and we sell a lot of things on the market that are actually problematic from this standpoint, are things that stop as soon as the child goes to sleep or shortly after the child going to sleep. So an example of that would be these machines that create light on the walls and have sounds or music, and they last for maybe, 15 or 20 minutes, and then they turn off. If that's part of what a child has when they're falling asleep as an element of their routine, and that's not happening when they come up into these arousal states during the night, that can result in them becoming fully awake. And also, television is a part of the bedtime routine, or iPads and watching YouTube videos or whatever are not a good practice because they really interfere with nighttime sleep because of the exposure to screens and the blue light, and that interfering with melatonin secretion. So some other impediments to sleep, or things that might contribute to sleep problems, are using beds as a place for punishment or play. Researchers and people who work with families with sleep problems really recommend that we only use beds as a place for sleep. Caffeine intake after noon can be a problem for children, and for younger children, any caffeine intake at all if you're trying to get them to sort out naps. And that can include chocolate, ice cream, pop, and energy water, and instant breakfast. So there's things that you might not think would have caffeine in them, but they do. Often when I talk to families, dads are coming home from work late in the day, and I'm not trying to pick on dads here, and they haven't seen their children all day, and they really want to spend time with them and have some close moments. But sometimes with fathers, and that's a wonderful form of play that they have with children, that can involve rough games and a lot of stimulating games, and that can actually interfere with nighttime sleep if that's happening right before bedtime. And we've already mentioned parental. Parents are lying with the child. We want to avoid light, warm, noisy bedrooms, and also having pets in children's bedrooms, because many of the pets children have, like hamsters or gerbils, are actually nocturnal animals, and they really are very active during the night, and if children are light sleepers, that can interfere with their sleep. As Graham said, sleep is a family affair, and it is absolutely critical that there's between-parent consistency. If there's between-parent inconsistency, and one parent's trying to set limits and the other parent is undermining that, you're not really going to get much progress on dealing with children's sleep problems. And I've already mentioned about blue light, so we really want to avoid electronic entertainment and communication devices in children's bedrooms at all, because we now know that a lot of children might have their iPhones in the room with them, and they might have them texting during the night, or they might be receiving texts, and that's going to interfere with their sleep. We really want to create consistent sleep schedules, as I mentioned, and depending on age, we really want to aim for bedtimes that are around 7 to 8:30, certainly no later than 9, because a national survey has shown that children, well, toddlers at least, who have bedtimes after 9 p.m. sleep on average 1.3 hours less than toddlers with a bedtime before 9 p.m., and preschoolers with a late bedtime sleep around 48 minutes less on average than preschoolers with an early bedtime. And as Graham said, we want to avoid determining bedtime on whether the child looks tired or not, because a lot of children, as they get fatigued, are going to get hyperactive, and parents might be thinking, oh, they don't look tired, I don't really need to put them to bed yet, but they're actually getting overtired and are going to be more difficult to settle. As Graham pointed out, often teenagers try and make up for short sleep duration on weekends and sleep longer, but we really want to try and make bedtimes as consistent as we can, even for those older children, and adolescents through the weekend on weekends. I know it sounds like it's highly unlikely, but we can at least try and aim for that, because it really, if we have inconsistent bedtimes, it's an impediment to sleep. A lot of children need cues prior to the bedtime routine, indicators that, okay, we're going to start to get ready for bed now, and your routine's going to start, because it helps them get their heads around it's time to go to sleep and to relax into sleep a bit more easily. So no cues prior to the bedtime routine can be a problem. As I mentioned, inconsistent naps or very short naps, so children who are only napping for 20 minutes, we call that cat napping during the day. That is not enough time to actually help with their sleep drive and to achieve restful sleep. So those children are going to get more hyperactive over the course of the day, and they're going to be more difficult to settle at night and to have night sleep without night waking. And of course, if we provide no opportunities for children to sleep independently, then that's going to be a problem with their sleep and difficulties falling asleep. So we think of limit setting problems as requiring more than 20 minutes to fall asleep, or excessive demands at night to delay sleep. And I'm sure you've all heard parents talk about this. This is when the child says, oh, I want one more story. Oh, I need one more drink. Oh, I need the potty. Oh, please come and sing me one more song. Or I want to look at one more video on my iPad or whatever. And when parents aren't very good at limit setting around that, then it can drag on. And I've talked to some parents who have bedtime routines, and I put that in quotation marks, that last anywhere from an hour to 2 hours. And so really it means that the child's not going to bed at bedtime. The child's really going to bed about 2 hours later than bedtime. So that makes for very inconsistent bedtimes, because sometimes you might get through your routines in a more timely fashion, and other times you could be spending 2 hours going through your routines trying to get the child settled. And children who fall asleep with a family member or parents being present also have more problems with limit setting, because they anticipate that the parents are going to be there when they fall asleep consistently. So that makes difficulties that parents would like to go out at night and maybe have a babysitter or another family member caring for their child. But it also creates problems when children have arousals during the night, because if the parent's not there, they'll fully wake themselves up and go looking for the parent if they're old enough to get out of bed and do that, to help them fall back asleep again. So treatment of common sleep problems. I really don't use the term extinction very often with parents, although that is the term that's used in the literature, because I think it's a term that most parents react to quite strongly. But there can be what we call standard or graduated extinction, camping out or fading parental presence, limit setting strategies, or what we call bedtime fading. Those are all approaches we can use, and I'm going to go into more detail around each of those. So standard or graduated extinction, these are approaches that teach children to fall asleep independently. Standard extinction is really where the parent puts the child in the bed, closes the door to the bedroom, leaves the room, and leaves the child to cry until he or she falls asleep. There's been no evidence to actually show that this has negative effects on children, but it certainly is something that parents find really difficult to do. And so I generally don't recommend standard extinction for parents unless they are really at their wits' end and they've tried everything else, because they're very often uncomfortable with it. And if you are asking parents to do standard extinction or graduated extinction, you need to let them know that children on the first night often seem to do quite well with it, but often on the second or third night, it's like they figure out that this is now part of the new normal, and there can be a very strong protest that happens. And that can give parents the impression that, well, this isn't working anyway and we should just give it up. But actually, if they can hang in there through that second and third night, they can start to see real improvements happening with their children. And this approach can take 7 to 10 days. And graduated extinction, which I usually refer to as controlled comforting, is a technique that permits short visits to the child for the caregiver to offer brief comfort and reassurance and then to leave the room. And with graduated extinction, generally what we advise is slightly longer times out of the room, so that you're out of the room for up to 20 minutes. So that can be 2 minutes, 4 minutes, 6 minutes, 8 minutes, increasing 2 minutes each time. Or if parents find the child's not responding that well to that because maybe it upsets them, or for the parents to be going into that regularly, they could do 5-minute intervals, and they do that up to 20 minutes. And then they stay out of the room for 20 minutes at a time and then go into the room to offer the child, again, brief comforting techniques and then leave the room. The idea with controlled comforting is it offers the child an opportunity to self-soothe to sleep while a parent or caregiver is out of the room. And this can also take a few days, usually around a week. I recommend that parents keep logs when they're doing these forms of treatment for children with sleep problems, because sometimes there's very gradual improvements in the child's sleep. And when parents are already overtired and they're already having difficulty problem solving because they're so fatigued, if they don't start to see immediate huge changes, they can give up on it, which actually can create more problems down the road. So a sleep log can help them to see some of these subtle changes and feel like they're making progress and reinforce that they're on the right track. So camping out or fading parental presence, this is for parents who really feel that their child should not be left to cry under any circumstances, even for brief periods of time when they're out of the room. And this involves having the child either sit in the child's room on a chair or lie on the floor next to the child's bed if the child's older and they're in a bed. And gradually, what the parent does is they remove their presence from the room. So the idea is that every 3 to 5 nights, they move a little further away from the child. They don't interact with the child while they're in the room. For children who really like to engage with parents on a very intense level, it's good not to make a lot of eye contact. And then by the time the parent's out of the room, the idea is that the child is learning to soothe to sleep and themselves to sleep, and they no longer require parental presence. This takes quite a lot of patience on the part of parents, and it can take up to 7 to 14 days. The other problem that can come up that I haven't got on the slide is early waking. And I encounter quite a few parents who've said that it's difficult if children are waking up at, say, 4:30 or 5 a.m. and they seem like they're ready to be up for the day, and the parents are certainly not ready to be up for the day at that point. And what you can do with that for older children is you can have a lamp attached to a clock or what we call a night clock that offers a visual cue for the children that it's not time to get up yet, and when the light turns on or the clock turns green, then it's time for you to get up, and meanwhile you need to stay in bed. For the children who are still in cribs and are younger who are having these problems with early wakes, sometimes they're just needing one more sleep cycle. So it's really trying to use controlled comforting or some of the other techniques I've talked about to try and get them back to sleep so they can get through one more sleep cycle. And then they're more likely to be getting up for the day at around 7 or 7:30. Okay, for the limit setting strategies, this is really making sure that parents are setting limits at bedtime and during the day. And this is trying to make sure that you're giving the child clear messages that the sky is not the limit and they cannot have routines or activities that go on for 2 to 3 hours in the evening. So an excellent technique that can be used to help them with setting limits at bedtime is the one free pass technique, and that's where you make a piece of paper and you put one free pass on it, and the child gets that free pass, and then they are told that they demand one more drink or one more trip to the toilet or one more story, they have the free pass taken away, and that's it. They don't get any more opportunities after that. And a lot of children understand that quite well. It's best to avoid arguments about when to go to bed, but offer the child choices of which book to read and give them some control over that. You really want to praise a child for the desired behavior and let them know that you're really proud of them, that they're working on this and they're making progress. And you can use stars on a chart and then give the reward of a favorite activity after 3 to 5 straight stars, or a little under the pillow surprise or something like that. Because especially for the older children, just putting stars on a star chart generally isn't enough incentive to help them want to carry on with this, what you're asking them to do for you. And with older children who come out of their rooms, walk them back to bed. We can tell parents, say the door will be closed if the child does it again. Advise the parents to next time close the door and hold it shut for 1 minute, and increase it by 1 minute every time they get out of bed. The thing to remember about the rewards technique is you have to gradually fade the rewards. Once the child, if you're a parent, or the child, if you're a care provider, is demonstrating the desired behavior, you don't just want to stop the rewards dead in their tracks, because the child will get very confused about that. So you want to gradually fade the rewards and make it more difficult for the child to earn the rewards. And this kind of technique can take, 7 to 21 days. It can take quite a bit of time. And then bedtime fading involves, this is for children who are very anxious about going to sleep and find that they really start to worry about falling asleep. And even once they're in bed, even if they're not getting out of bed, they have a very long period of sleep latency. And what bedtime fading involves is actually trying to put them to bed when they actually fall asleep right away. So you actually move the bedtime later to the time when you've noticed that the child can go to sleep immediately. And then gradually what you do is you move the bedtime earlier, about 10 minutes per night, to try and help the child fall asleep immediately after being settled. If the child isn't settling well when you do that, you can take them out of the room for a little while, have them in a quiet and dim area, undertake calming activities, and then try and put them to bed and resettle them. And it can be very useful, as I said, for older children who have a lot of anxiety about falling asleep. So
we're running just short on time. I'm not sure how many slides you have left, but just wanted to just mention that we are running a little bit short on time.
Okay, thanks, Doug. I'm just briefly going to talk about parasomnias and sleep apnea, because we want to make sure that if it's a behavioral sleep problem. So,
Wendy?
Yeah?
So we have 35 minutes left till we have to end, and we want to cover Better Nights, Better Days as well. So I think that we might want to just skip over some of it so that we'll have time to present and have some questions at the end.
Okay, sorry, I was watching my clock and I didn't think I was over the time, but that's fine. So we'll just skip through the parasomnias. You'll have the slideshow so you can look at what these are and how they're defined and when they happen. And also there's the slide on obstructive sleep apnea, and you want to make sure that the child doesn't have that going on, or restless legs, and that's getting treated. And we want to rule out some of these illnesses that can affect sleep because they need to be treated before we start to deal with a sleep problem as a behavioral sleep problem. So we're ready to move on to Penny.
Excellent. Thank you, Wendy.
All right, and we will save the questions for the end just so we can make sure we get the content in, because there's just so much great information here to go through.
Excellent. Well, thank you for the opportunity to share with you our, I think, exciting news about our upcoming launch of an online behavioral intervention for parents of children with insomnia, and it's called Better Nights, Better Days. And I think as I go through my talk, you'll understand better what Doug was saying about it's been a couple of years or more since we first started planning this. You'll see some hiccups along the way. So I'll share those as well as a learning opportunity. So this is a study funded by CIHR, and it's one of the team grants. So there's 5 given out, and only 1 on pediatric sleep, and it was the one for Better Nights, Better Days. So it's a very exciting opportunity provided by CIHR. The investigators are listed here. So I'm the principal investigator. There are 8 management team members who are also pediatric sleep researchers and as well clinicians from across the country, different disciplines, psychology, nursing, medicine, including respirology and neurology. We have a wonderful advisory board in terms of pediatric sleep of folks from across Canada that have different areas of expertise. A wonderful scientific advisory board, so pediatric sleep from an international perspective with Judy Owens, but also covering methodology, statistical analysis, e-health, knowledge translation, etc. And we have a wonderful knowledge translation advisory board, and the Canadian Association of Pediatric Health Centres is one of those team members. So we really appreciate their support. And I don't want to forget all the staff that are critical. So Becky is the project manager. Sydney is the incoming project manager. So we're losing Becky, which is very sad. Esmod is the research associate who's done all our data preparation and database development. Gabby is a postdoc who's working on the project, and Julia is doing communications with us, and she's tweeting, etc. right now. And we have 2 research associates, Amanda and Anna, who have been also involved. This was my birthday cake the other day. They were very kind and dropped by. So Better Nights, Better Days is focused on insomnia in children ages 1 to 10 years. And as Wendy already spoke about, insomnia is a common problem, and it has a variety of symptoms. So resisting bedtimes, trouble falling asleep, night awakenings, and waking too early in the morning. And obviously, based on what Graham was saying, this has significant impacts in terms of the children's physical and psychosocial health, as well as the caregiver's well-being. The good news is that we know how to treat insomnia in children. So there are some very highly effective behaviorally based treatments for insomnia. In fact, research shows about 85 or more % of these children with insomnia actually will have clinically relevant and meaningful changes in their insomnia symptoms based on a behavioral intervention. The bad news is that it's only 1% of children actually receive these behaviorally based interventions, which is quite sad. And instead of the appropriate interventions, children are receiving medication, which actually has not been shown to be effective in this pediatric population. So why is this happening? First of all, parents may not know that it's appropriate to seek out support and help. Someone else has their mic on. To have help about their child's sleep problems. And health professionals also receive very little training in pediatric sleep, and there's very few available resources. All this leads to a situation where insomnia is not being treated often in children. When it is being treated, it's traditional treatment delivery methods. And so this would be face-to-face, weekly meetings with a therapist or clinician and a parent. And this can be very difficult for parents, both from a time and money perspective, having to pay for travel, having to take time off work, etc. And so we wanted to develop an intervention that would increase accessibility for parents across Canada to get these interventions that are known to be effective. And so we decided to go with an online treatment delivery model. So I think just for time's sake, I'm going to skip over the poll, but e-health is, I'm sure many of you know, is a kind of a growing way of delivering interventions. And we actually find that adherence rates are even better in e-health interventions, probably because it can be accessed from the home at a time when the parents can actually find the time to do the intervention. There's a good evidence across many different disorders that have been treated with e-health interventions that this can be effective. In fact, it can be effective even without coaches if you use a sophisticated program. And it has many benefits outside of accessibility. There's also benefits in terms of cost effectiveness, how scalable it is, so how many people you can reach, and you can personalize and tailor content. So I thought I'd share a little bit about the development, and here you'll see why it's been so long. So our goal was to take empirical evidence along with interventions that had already been developed and tested by the team. So I had completed a randomized control trial of school-age sleep intervention. Graham had completed an RCT of a preschool intervention, and Dr. Shelley Weiss had written a book about sleep in infant and toddler using evidence-based intervention. So we thought we'd take all of this and develop the content for the intervention. And we were going to use an informed delivery method. So we really scoped out what are the instructional educational sites, how are they delivering information, what are the best practices based on evidence for delivering it on the web, and incorporating e-health and behavior change models to really be able to impact parents and to make the changes so that they can make the changes in their children. And what we found is that what would be best would be to use video-based information that has to be engaging, there has to be goal-setting activities to support what they're learning and tracking their progress. So this meant kind of going back to the drawing board, and so we couldn't just take what we had and put it on the internet. It wasn't that easy. So we actually had to go back and define everything that we were going to do, develop all the scripts and copy editing to develop these videos. So it was a very long process. It was a couple of years, and we were really happy with the progress we made. The sun was shining, but then something happened, and the clouds became dark, and thunder and lightning happened. And the company, the web-based company we were working with, actually disappeared, let's say it that way. And so we had to start again, which was really quite sad. But it all turned out good because now we're working with a wonderful company. But we had to take our platform and all our content and what I call as a retrofit. So we had to retrofit everything to a new platform, which involved developing new web flows and new prototypes and reviewing and sessions and testing. But I'm happy to report now we actually have the finalized, or we're so close to the finalized interventions. We're doing the last quality assurance tests, and we're almost ready, and it's looking really fantastic. So sometimes I guess it's a silver lining in a bad situation, but I think ultimately will be the best. And so the company we're working now with is called B-Health, and they're out of Virginia, and it's a behaviorally based a company that develops e-health interventions and tests them for behavioral problems or behaviorally based health problems. And so they're very knowledgeable. Lee Ritterband, Francis Thorndike are some of the founders, and these are leaders in the e-health field. So happy to be working with them. So our intervention is an online program that provides accessible, evidence-based treatment for parents of children ages 1 to 10 with insomnia. This is a little video, and I'm just trying to figure out if we have enough time. I'm going to skip the video. If we have time at the end, we can show it. The program is comprised of 5 sessions. So first, just general sleep information. So all the stuff that Graham told you, but in a sort of dynamic video-based format. Then the information about healthy sleep practices. So this is all the stuff that Wendy told you about, the impediments to healthy sleep, or sleep hygiene, it's often called. Session 3 is how do you settle to sleep? So using our behavioral strategies to help children sleep. So teach the parents how to do this. At bedtime, session 4 focuses on falling asleep at other times, so night awakenings, early morning awakenings, and during naps. And session 5 is a relapse prevention kind of approach. So what are the problems that might come up in the future, and how might you address those in order to ensure that your child continues to have good sleep? And parents have to complete the program within 5 to 10 weeks. Some parents might have less problems, so they'll go through the sessions quicker. Some might have more challenges and have to take more time. So the program is quite dynamic and I think motivating. There's sleep diaries that they complete every day. They're quick, simple, and those are all charted so they can see how the progress that they're making. There's weekly activities that they can engage in to help implement the strategies. There's review information they can print out, and they set goals and they see indicators of their progress. So it's very dynamic and engaging program. This is the first screen on the first page, so it's welcoming them. You can see that there's different age ranges and different families represented, and they could click each of these pictures to hear a little more about these parents' experience with the program. So we're trying to engage that. I'm just going to walk you through the taskbar at the top. So the how to use, so this is an instructional instructions, video-based instructions on how to navigate the site. the session. So this is the 5 sessions that they could go through and learn about sleep, learn how to help their child's sleep problems, and receive, they can download information. It's all web-based, or video-based, I should say. They can access sleep diaries and the charts that go along with that to monitor progress. Then everything they do goes into My Stuff, so they can download any of the information that they have already completed. So this is a shot of the home page for the session. So you can see that where they select each one. They're different colors. So right now this is a screenshot of someone who has completed all sessions. So they're all pink. They start out transparent and then change colors as they go along. You can also see in the far right a reward center. So parents can actually build a reward chart to use to help support these behavior changes in their child. It's again a pretty dynamic, interesting program. There's engaging videos. So we have Ashley, who is really the coach for the parent. She's a virtual coach. They can't talk to her, but she kind of walks them through the program. So we have her live talking. We also have her cartoon form, helping the parents understand different concepts. This is an embedded video that the parents would watch. There's engaging videos, as I had mentioned, with kind of fun ways of explaining things. So this is a video about the circadian rhythm as well as the sleep drive and how they work together. So an engaging way to teach parents about these facts. And also nice pictures that are engaging. So lots of visual stimulation, I think, and visually interesting and engaging. We also have sleep experts who share information and concepts. So this is one of Wendy sharing information about a topic. We also have ways of tailoring content and information based on the child's age and sleep problems. So, for example, this is about giving your child a little more attention and affection when you're doing things like changing sleep that can be challenging. So if you're a parent of a child of a toddler, you actually can go into this link and learn more about how to do it with a toddler and other parents of toddlers' experience. And so they can really get that more age-specific information. We also have interactive activities that reinforce the program content, so parents would fill this in, and they would get tailored feedback based on their responses. So again, ways to engage parents. Parents set goals. They decide what's high, medium, and low, and their progress on these goals are charted, and they can access their progress at any time to see how they're doing. At the end of each session, they can download a session plan. This helps them, that tells them how to implement all the strategies for the week or the 2 weeks that they're going to work on that session, and it gives information about those strategies. They also get summaries of all the content that they've been exposed to. And then we also use the concept of a roadblock, so common barriers or problems that parents face in order to, when they're implementing the strategies, and we use roadblocks to help them around these common barriers. And this is all downloadable, saved. They can save it on their own computer. So some of the advantages of Better Nights, Better Days, first of all, obviously, it can be accessible to many more people because it's a distance treatment program. Also saves time and money for families, and I think the healthcare system even. And it gives support to the parents from start to finish. It's not support in terms of like there's no face-to-face contact, but it's built-in support and program tools and guides that are used to motivate the families. And we really try to empower the participants or parents during this program so that they feel that they can make the differences in their children's lives and their sleep. So we're starting a randomized controlled trial with a goal of recruiting 500 participants. So this is parents or caregivers of children the ages 1 to 10 who have insomnia. And it's across Canada, and we're starting in June, so we're getting really close and very excited. And scared a bit, but excited more. In terms of who can participate, so it's children, parents of children who are the ages of 1 to 10 years. They have to live in Canada. The parent has to have regular access to high-speed internet and email, which is about 80% or more of the population in Canada now. And those that don't can often access it at a library or a school, so really feel we can reach a lot of parents this way. You have to write, read, and understand English or French, so it's a bilingual program, which is really exciting. Their child has to have insomnia, obviously, and they have to want to support their child sleeping independent, because that's really one of the key components of the intervention, as Wendy outlined. And also the child has to be typically developing and healthy to participate in this particular research project. And you'll see that Better Nights, Better Days website URL here, and so if you want more information, you can go to that website. In terms of steps to study participation, so the parent should be directed to the website where they'll do a quick self-screen to see if they meet the criteria. If that is positive, they go into a more extensive screening process, leads to a determination of their eligibility. If they're eligible, they go through a baseline assessment where they have to fill in sleep diaries, questionnaires, and their child has to wear an actigraph, which is a wristwatch-like device that measures their child's sleep, and it's an objective measure of the child's sleep. Then they're randomized either into the active intervention, Better Days, Better Nights. No, the other way around, Better Nights, Better Days, sorry, hopefully it works both ways, or into usual care, which basically means they don't get the intervention during the study time, but they can access what they usually would access. And then there's follow-up at 4 and 8 months. At 8 months, the Better Nights, Better Days intervention group is completed, and the usual care group then receives the intervention. So everybody who participates will get the intervention. We really see this program, I mean, it's a research study. We want to test for the effectiveness. If it's effective, we really see this fitting into a stepped care model of care for pediatric insomnia. So there's just not enough healthcare providers to deliver this treatment to as many children that need it. So if we could help parents of children with mild to moderate insomnia, we could actually then leave open the specialists and the experts to work with children with more severe problems. So again, this is a website, and I also wanted to share some news, which again, very exciting, is that we just received funding from NeuroDevNet to take this intervention and modify it for children with neurodevelopmental disorders. And we're going to be focusing on 4 different types of neurodevelopmental disorders for this study. It will be children with ADHD, children with autism spectrum disorder, children with fetal alcohol syndrome or disorder, and children with cerebral palsy. So we'll be taking what we've already developed and modifying it. So we're working on that right now. We're hoping to launch the second version, the version for neurodevelopmental disorders, in 2017. So remember us for both. And just a note that if you're interested in learning more about Better Nights, Better Days, we'd love to share more information from you. We really want to have a successful randomized control trial and get people involved. And so I think there'll be a quick poll that will just answer yes or no. If you put in yes, that means that I have a note here. People could. It
just means if you click yes, we will share your contact information with the team here, with Penny and the team. And if you select no, then we won't share your contact information. But if you do want them to follow up with you, we will share your email address if you click yes.
Yeah, and so I think right now that's kind of my overview of Better Nights, Better Days. And so we have about 15 minutes left to answer any questions about the information that Dr. Reid or Dr. Hall delivered, as well as about Better Nights, Better Days. Also, just a note that if you download the slides, there are some resources and references at the end of the slides that you can look at a later point. So let's open it up for questions, Doug.
All right, so we do have a lot of questions, and a lot of the questions that came in earlier, I think, were asked later in the presentation. So we may either skip those or maybe just brush over those. Like one, for example, was someone asking for an easy sleep log for parents. And I think that really, as part of the Better Nights, Better Days tool, you have the sleep log built into that. Is that correct, or do you recommend anything else as far as a sleep log for parents?
Yeah, so definitely with Better Nights, Better Days, we've been working really hard at developing a sleep diary or a sleep log that the parents will complete online. It is a challenge. There's actually there's very few that you can access for your own clinical use, let's say. There is one through the National Sleep Foundation that you can purchase to use. There's one at the resources in the web on the PowerPoint presentation. There is a log that you can download, And what I'd like to see in the future, we're trying to develop resources. So in my lab, we're also developing other resources. So we're working on getting a sleep diary online that healthcare providers can use for their own clinical purposes. So if you're interested in participating in that project, you can also send me an email. But yeah, there's really few resources, and I think we have to build the resources in order to really meet the needs of this population of kids.
All right. And as far as participating, just to recap that, because we do have a lot of interest in hearing more about participating, it's any family in Canada, and it's really just that Can I Participate link or that information on the page on the website that's on the screen right now. That's the way that people participate in this?
Absolutely. Yeah, just click the Can I Participate right now because it's not live. We'll just collect your email address, and once it's live, we'll get back to you, and then you'd come back and you'd fill in you would be able to fill in more information to see if you're eligible. But the eligibility criteria are listed on every page in the box on the left-hand side that says, Can I Participate?
All right. So we did have a number of questions that came in back with both Dr. Reid and Dr. Hall. So we'll go back for some of those that came in during that point. The one question was asking about the AASM. I assume that's the American Academy of Sleep Medicine, or something along that line. Correct me if I'm wrong on that. But Sarah has said that she's heard that there are new pediatric sleep guidelines from that organization. Are you aware that there were any recent updates to sleep guidelines from that organization?
There are recent updates coming out, Doug. It's not a definition of a sleep problem. It's guidelines about sleep duration, and those are supposed to be coming out in June.
Okay. And regarding duration, you did put up, there's lots of information in the slides about sort of total duration. Could you just recap how you measure total duration when it comes to preschool-age children that are napping during the day? So when you had the ranges of 9 to 11 or 13 hours, etc. Does that include naps? And if not, how long should an afternoon nap be?
So, that's critically important when you're looking at total sleep duration with preschoolers and infants to include naps. And the data, depending on the study, the one I showed included total sleep time over 24 hours. Naps typically vary depending on age, but for preschoolers, it's typically about an hour. Wendy, do you want to chime in for younger kids?
Sure. So for the younger kids, it's often common for them to have a nap in the morning and a nap in the afternoon, and they can last anywhere from an hour to an hour and a half. So it's important to factor that in when you're looking at what the total sleep duration is over 24 hours, because even if they're getting slightly shorter nighttime sleep, it may all add up to an appropriate amount.
And there were a few questions around seasonal variation in sleep patterns and circadian rhythms. Does that affect the sort of the parameters that you were talking about, the sort of the wakefulness and the competing with the sleep, the efforts to sleep, etc., or the alertness drive and that sort of thing? Is that affected by seasons at all?
I think one of the things that we know in Canada is we have a lot of variability in terms of daylight. So particularly when we talked about synchronizing, sleep drive and other circadian factors, exposure to daylight makes a difference. When you're exposed to light late in the day, it tends to shift us towards a later bedtime and a later rise time. When we're exposed to light in the mornings, it does the opposite. We tend to shift towards an earlier rise and an earlier bed. It's hard to disentangle some of these factors in Canada in particular with school holidays, right? So at the same time we've got changes in light, we're also getting changes in people's demands. There's more vacation, there's less need to get up and going in the morning for many children. So I think both are at play when we tend to think about seasonal shifts.
All right, and Wendy as well, because you guys are sort of focused on the different age groups, if there's anything that's sort of unique or different with the different age groups that you both sort of focus on, please don't hesitate to jump in. We did have a number of questions, and it was great to see at the end, Penny, with your talk around the partnership with NeuroDevNet and the focus over the coming months, years, to sort of translate this to be relevant to children with disabilities. We had a number of questions around sleep interventions for children with developmental diagnoses, with other children with disabilities and that sort of thing. So we will have this tool, and you are going to be doing some research in this area. Have you done any research, or is there anything that and I'll open this up to any of you, sort of how does all of the stuff that we've talked about today with respect to sort of typically developing children, what could we typically expect to be different with children with either physical or behavioral disabilities, et cetera?
That's a great question. So it's what we're working on right now. So we're doing a number of studies kind of leading up to making this modification. And the first study we are working on in the publication was a systematic review of all the literature on sleep interventions with children with neurodevelopmental disabilities. And I think what's really interesting is that many, or let's say even all, of the strategies that we use with typically developing children do work with children with neurodevelopmental disabilities, but need to be modified to meet the needs better. So some of the modifications that seem to be supported by evidence would be longer times to implement the strategies, more support for the parents, problem solving around some of the other issues like anxiety, sensory problems, mobility problems. So we really have to think about those things. So the approach we're going to be taking in the neurodevelopmental disability kind of version of Better Nights, Better Days will be looking at some of these other factors. So not so much disability specific, but what are those factors that cut across these neurodevelopmental disabilities or disorders? So sensory issues. How do we deal with sensory issues when we work with children who have sleep problems and who have NDD? So that's the first study we did in order to kind of move ahead. The second study is a Delphi study. So we've gone out to the experts in sleep and neurodevelopmental disabilities and said, what do you think we need to do to modify this intervention? So we're in the last round of that, so we're collecting information there. But again, I think the same story is coming up, which is we can use the same strategies, but we need to adjust them for the different kind of demands and concerns. And then we're also doing a third study, which is asking parents and healthcare providers who are kind of front line, what they see as barriers to these interventions. And so we're running a number of focus groups and absolutely would love to have some participation in them. We're having a bit of a hard time recruiting. So if you're a healthcare provider or a parent of a child with ADHD, autism spectrum disorder, fetal alcohol syndrome, or cerebral palsy, and your child or your clients and patients have sleep problems, if you contact me at penny.corkum@del.ca, maybe someone could put that up on the website or on the webinar. We'd love to have you involved in that and give us your input on what you think needs to be changed to make these more appropriate for parents of children with neurodevelopmental disabilities. Sorry, that was long-winded, but I'm excited about it.
Kristen was asking, and I think she says she thinks this might be appropriate for Dr. Hall. She's interested in hearing about when behavioral sleep interventions might not be appropriate. Are there any situations in which that would not be an appropriate intervention?
Well, yeah, that was the part that I kind of skipped over at the end there. We want to make sure that there's not, and this partly fits in with the work that is happening around children with neurodevelopmental disorders. There's not any underlying pathophysiological elements that are going on that are interfering with the child's sleep. So things like if they're itchy during the night because they've got eczema, or they've got an ear infection and so they're in pain, or there could be a variety of reasons why they're waking up during the night or having difficulty settling that we need to sort first and treat before we start to look at whether a behavioral intervention might be helpful.
So let me just jump in to say that, the challenge here again is accessing specialized services. So some of the things that Wendy just went over may take time to assess. It's hard to imagine that there's going to be any significant adverse effects with doing the things just in terms of routines. Working on kind of consistency in terms of bedtimes, rise times, and having a good bedtime routine, really there's not many risks associated with that. I think the frustration would be with parents is if you go to the next step of that intervention, it may not be helpful when there are other factors which really need to be addressed.
All right. All right. Thank you for that. We did have a bunch of questions for the slides, etc. Those will be available on the Knowledge Exchange Network. They're also they've been uploaded to the control panel, so you should be able to download them straight from the control panel if you want them now, or they will also be on the CAPC Knowledge Exchange Network, and you can access them there as well. Let's see. We've got lots of questions about children with disabilities, but I think we've already talked about that. Sarah's saying terrific program and website. She's just wondering what the primary outcome of your randomized controlled trial was that you were talking about, Penny.
So that's a great question. It took a lot of debate and thinking about that. So we're using a kind of combined primary outcome using both a more subjective and objective measure of sleep, so sleep diary and actigraphy. Will be collected at baseline 4 months and 8 months, and our primary variable in terms of outcome is sleep efficiency, but then will be broken down into sleep duration and sleep quantity and sleep quality variable. So we want to see both things happening. We want to see the children sleeping longer, but also having better sleep quality.
All right. Do you have any research around, this is a very sort of popular issue in the last number of months, around the whole issue around blue screens interfering with melatonin letdown, et cetera, using screens before bed and the blue light affecting sleep before bed. Is there any research around that solid research around that you can comment on?
Yeah, I would say, and maybe Graham can follow up with more details, but in terms of our systematic review that we conducted, looking at sleep hygiene or healthy sleep practices and the types of things that we tend to recommend, the one with the most evidence, empirical evidence, is definitely around screens. And they have been shown to impact sleep. So that's a confirmed finding. What I'm not as familiar, I know that every company's coming out with changing the color and the frequencies, the illumination, that sort of thing, to try to reduce that impact. And I don't know if we know much about that. Graham, can you add to that?
Yeah, I don't think there's been an extensive amount of research done with children on the specific exposure to the blue light, to light related to screens. But I think the issue is that when it comes to these sorts of interventions, particularly the basics with good routines, getting kids to bed, it's not like a sleeping pill that you take it kind of knocks you out for 8 hours, and then when it clears the system, you're back to awake. I think it's important to think about every little thing that happens on the path to sleep increases the likelihood that children are going to be kind of relaxed and able to fall asleep. But because access to screens with children, it's almost impossible to disentangle the arousing effects of simply, oftentimes they're chatting, they're not just reading. It's not like a tablet and you're reading a book. They're often chatting, interacting, being social late into the night. There may also be an effect of the exposure to light.
All right, and we do have quite a few more questions. I think a lot of them, are resources that could be answered by the resources that are on Better Nights, Better Days, et cetera, just sort of general questions about how to improve sleep in children, et cetera. So we'll take a couple more before we go, and then we will wrap up. And before we go, Dr. Corkum, maybe we'll just go over to you for any sort of final key messages that you would like to leave the audience off with. So you can sort of start thinking about those a bit before we get to that. But the one question was, first for you, Penny, is prematurity an exclusion criteria for participating in the program?
I think no, not as long as there's no current medical or psychological mental health problems. That would be fine.
Right. And Dr. Hall, this may be most appropriate for you. Any of the sleep research that we've talked about here and the interventions, et cetera, how would they apply to infants that have been born premature and maybe struggling with some of the impacts of prematurity? Not significant, like not someone that's still in the NICU, but the baby who's gone home. Is there anything unique in the premature infant population?
That's a really great question. They are going to have been exposed in neonatal intensive care nurseries to 24-hour stimulation. And so often for them, it's very difficult to make the transition when they go home, and it's very dark, and there's not a lot happening at night because they've been exposed, as I say, over 24 hours. So parents need some extra support around what to do for those children, because some of these kids have really learned to sleep with a lot of bombarding going on, and they react to very quiet, dark environments. So it just takes more work to try and help them make that transition to home life.
That, even though we do have lots of other questions, and I think we could probably stay here for another hour if we let the audience keep asking the questions. I think they would fill that next hour, but I don't think we can do that. I think you've given us enough of your time and some great information. So, Dr. Corkum, maybe some closing comments for you, just sort of as the lead of this project, and just any key messages or thoughts that you'd like to leave the audience off with.
Yeah, putting me on the spot here. Just teasing. So, I mean, I think just to summarize, I mean, obviously, pediatric insomnia is a highly prevalent problem. It has a significant impact on children and families, and we don't have the treatments available. It's easily accessible. And so I really think that, Better Nights, Better Days potentially could fill this gap in terms of service delivery. If we could meet the needs of this very large population of parents and children, we might see really positive outcomes in terms of the child's functioning, the parents' functioning, and then really have our experts address the more complicated issues related to some kids with pediatric insomnia. And so, I just like to encourage people to share information about Better Nights, Better Days, send families to us by going to the website, talk about it, and, we'd love to run this trial, see if it works, and then the whole point about Better Nights, Better Days and the funding was to make something that's sustainable. So we've worked with a company that's going to actually sustain this afterwards. So this is not a one-shot deal. See the research, then it's done. This is going to last. If it's effective, we hope to have it out there and accessible to parents for a long time. So that's, I think, the most exciting part is the sustainability feature of this for parents in Canada. So really excited about that part, and really happy to have been able to come here and share about Better Nights, Better Days and why it's so important to treat children who have insomnia.
All right. Well, thank you very much for that. As I said, fantastic presentation from all three of you. Just a real boatload of information. I mean, that was really fantastic. We could have split this into probably 3 different presentations and filled an hour and a half for each one. So really, really great. And lots of opportunity for people to find more information on the website that's on the screen there, Better Nights, Better Days. Please don't hesitate to get in touch with our presenters, because I'm sure they'd be happy to hear more if you're interested in participating in the research project or any other information that you would need from them. So thanks again also to the audience for such a great participation from the audience, lots of questions. I mean, we could really see that, as I thought 2 years ago when we started this, I knew there was going to be great interest in this, so it was great to finally get this presentation onto our stage. So we do our webinars every Wednesday at 11 a.m. Eastern Time, and as you can see, it's always great when you can watch live, because that discussion is really one of the best parts of the presentation. But when you can't watch live, we do record these sessions and make the recordings, presentations, any other resources available after the fact on the Knowledge Exchange Network. Next week, we're going to hear from our community of practice, CAPC's community of practice, on transitioning of children to adult services with a session titled Transitioning to the Future, Pediatric to Adult Healthcare Transition for Canadian Youth. That session is going to have a panel of transition experts led by Dr. Kush Amaria from the Hospital for Sick Children in Toronto. And they are going to talk about the work of the community of practice over the last few years as they launch a set of guidelines, discuss strategies for sharing and implementation of transition tools, materials, and knowledge, and review evaluation modules. Whether you're an expert or new to the field of transition, this webinar will, quote-unquote, transition you to the future of transitions for Canadian youth with special health care needs. And then on June 8th, we're going to hear from Dr. Kim Widger and Dr. Adam Rappaport at the Hospital for Sick Children in Toronto. About an EPIC, and that's EPIC in quotes, spelled EPEC, an EPIC journey across Canada to improve palliative care for children with cancer. And EPIC stands for Education in Palliative and End-of-Life Care. And that's part of a larger national project funded by the Canadian Partnership Against Cancer to enhance provision of palliative care. They assess the quality of palliative care provided to children with cancer and their families. And in that session, they're going to provide an overview of a larger project as well as the details of what's going well and areas for improvement in palliative care that's currently being provided for children with cancer in Canada, and starting with children with cancer and hopefully being translated across all children receiving palliative and end-of-life care. So some great stuff coming up in the next couple of weeks. Thanks again to our Better Nights, Better Days team for a great presentation today, and we hope to see everyone back here next week. Bye, everyone.